that's kind of an interesting thing. That means it's very, very common. Why would it be so common? It's a genetic disorder, we know. We have many genes for migraine now. Why would we want to pass these on to our kids? We think the genes that provide a survival advantage get passed within the population, but why would genes for headache have a survival advantage? Could they actually be affecting something else, perhaps, that had a survival advantage, and they just gave us headaches by accident? That'd be one way to think about it. This picture is to lead you into what it's like to be a migraineur. Now, most of us are looking at this. I am thinking southern France. Wow, I'd love to be lying by the pool. Those of you with migraine are looking at that cloud up there going, ooh, my headache's going to be coming pretty soon. So one of the things that we'll talk about is how it's a genetic predisposition, but you don't have to have a headache all the time. And we would like to know how to get it to go away. If we can change that genetic predisposition, that would be really nice. Then we wouldn't have headaches. Now, one of the ideas I want to bring up right at the beginning, because I think it's important, is neurologists have taught each other and then taught you that normal headaches and migraine are two different things. I'm going to try to convince you that they're not. Is there any evidence that migraine and headache are actually the same? Well, for instance, does normal headache come by the same mechanism as migraine, but they're on a continuum, with normal headache being smaller and migraine being bigger? So is there any evidence to suggest that? And why do my patients use the term normal headache anyway? That's a little weird. It's like saying, oh, I have normal knee pain. Well, it's really not normal for your head to hurt, yet it's so common within the human population that we say normal headache. And we don't even give our kids a trip to the doctor until they become refractory with a headache. So we kind of think it's normal physiology to have a slight headache. The thing that really made me start thinking that the littler headaches were related was when the triptans became available. In the middle 90s, we started to get specific medicines for migraine. They work on serotonin receptors. They're not pain relievers. They have very specific mechanism of action. Because they cost $50 a pill, we said, save these for your migraine. Well, the patients always know better. The patients consistently say, you know, if I take my medicine soon enough, it works. So they started taking the pills earlier, and they would take it when it was just still a normal headache before it became a migraine, and they work great for normal headaches. They're just much more expensive than you'd like to use for all of your normal headaches. So that was the first suggestion. Now, we don't prescribe them for normal headaches, but could we learn something from that? Does that mean that serotonin is somehow involved, since we know the triptans work on serotonin receptors? Does that mean serotonin is somehow involved in normal headaches too? And I began early on, because of what the patients told me, to say, oh, a little headache can grow into a migraine. And then what is it that distinguishes it as a migraine? It turns out there are other features that are added. Well, how do those features happen? They're so common and they're so stereotyped from one patient to another, we just think of them as migraine. We're going to talk about those features and how they're related to headache and how they might be related to serotonin. So the triptans work on serotonin receptors that are a particular subgroup of receptors called the 1B and the 1D receptors. These are feedback inhibitors of the release of serotonin. So we have serotonin receptors of many different classes. The ones that the triptans work on actually tell the serotonin releasing cells to decrease the amount of serotonin that they produce. Now, does that mean they're working on the blood vessels? If I'm struck by lightning now, you'll know that the FDA has eyes everywhere, but it doesn't mean that it's happening at the blood vessels. Yes, there are serotonin receptors at the blood vessels, but in my view, these are not acting at the blood vessels. There are more and more neurologists that are brave enough to come out and say the mechanism of this doesn't have anything to do with the blood vessels. Serotonin is all over the place. So just if it works at the serotonin receptor does not mean it's working at the blood vessels. Now, this is a drawing of where serotonin starts from. So these two areas, called the raphe nuclei, are where almost all the serotonin that we can record or measure in the brain starts from. These are little tiny nuclei that send out axons throughout the brain, and serotonin release is interesting in that it's released at the nerve endings that we've all learned about where neurotransmitters released, but serotonin is also released along the axon. There are little adaptations along the axons, and it acts really like a hormone. It bathes the brain every few seconds once we wake up, and it's kind of like having this little happy juice that as soon as we wake up, it bathes the entire brain over and over and over. Well, that's an interesting thing because where are those receptors that these triptans act on? We don't really know. And there's one other really interesting thing that happened when I was starting to get into sleep that made me think about the triptans, which is that REM sleep is one of the few states where the serotonin goes to zero. Now, it turns out to be important for two reasons. One, when the serotonin is high at night, like when we use a serotonin reuptake inhibitor and we artificially elevate the serotonin during the night, it prevents REM sleep from happening. Now, I'm making up a reason why it might be low during the night, and it turns out the electrophysiology of how the brain is behaving in REM sleep and while awake is very similar. And it appears that one of the things that distinguishes the two is what the serotonin level is. So it appears that as the cells that are going to push us into dreaming are going through their little checklist to make sure that you're really asleep, because you really do not want to dream while you're awake, as they're going through that little checklist, one of the things on the list is what's the serotonin level. If the serotonin is low, it means the first, oh, is she laying down? Yes. Are eyes closed? Yes. So there are certain things that they'll check through. As soon as the serotonin is low, then you can flip into REM sleep. But that also means, why don't we think about the fact that for the last 100 years, our patients come in and say, I had this bad headache. Sometimes they go in the emergency room, they get the Demerol shot, they go home, they go to sleep, and then their headache is broken. The little kids get a bad headache, vomit, go to sleep, wake up. They know that if they can only get into deep sleep, they can break the headache. This is what all the migraineurs have told us for years. Did we get interested in their sleep? No, because we don't know anything about it. So we were told that it happened in fat old men, and that's not usually where the headaches usually reside. So we never pursued that. I became interested in sleep by accident because one of my patients forced me to do a sleep study on her. That's about 10 years ago now. I had given her 4 preventative medicines. We spent 2 years together. I gave her 4 of the different medicines. Each time I would tell her about the mechanism. I would give her all this stuff about the science. I thought I was doing such a good job, but her headaches never went away. So then at the end of the 2 years, she says, look, I need a sleep study. My husband says I snore like a train. And I say, I don't know anything about sleep. I can't help you. And she said, well, do it anyway. So we do a sleep study. She turns out to have terrible sleep apnea. She's not overweight. She's 32 years old. And she puts on the CPAP mask, which is unimaginable anyway. She has a headache every single day. She's willing to strap this thing on. And 6 weeks later, she has no headache. And I'm just totally blown away by this, thinking, well, this is a whole new area that I could pursue with my headache patients in whom I have limited success with the preventatives. They work sometimes, but then they wear off, and then we have to try something else. And patients who have daily headache will try anything. I mean, they've had a headache for sometimes 30 years. They will do anything. So they'll do a sleep study. So I did a lot of sleep studies on daily headache sufferers. Now, it turns out that they were all abnormal. The confusing part was they didn't usually have apnea, okay? So the next question would be, and we'll go through what their sleep studies look like, but I've been doing this for 10 years now, and there still aren't that many studies about sleep disorders in migraine patients. There's a few posters, it's just not a big area yet, and so I kind of wonder why it is that we haven't gone in that direction. So I kind of wonder if perhaps the people who write the articles, you know, if you stay a sleep specialist, you only do sleep. If you stay a migraine specialist, you only do migraine. So maybe just because I'm de facto sitting here and doing several things, I've stumbled into a couple of things that I think are really, really helpful. And the most important thing is if you stick with the vascular theory of migraine, you really just can't get your head around these calcium channel mutations. Most of the people who lecture about migraine stay with the vascular and they just ignore the 40 or 50 genes for migraine that have nothing to do with the blood vessels. So let's try to think out of the box. I think that what the patient says is always right. My theory is I make up a story. Humans are compelled to tell other human stories. That's what I'm doing when you come to see me. I'm making a story up. If my story fixes your headache, my story might be a little more valuable than what the other stories were. We used to look at it as if the story's written down in a book, it must be true. My daughter taught me that her generation is a lot more skeptical. If they see it on the internet, they don't necessarily believe it, and they have a much different way of thinking about ideas. So I think that what the patient says is actually the only truth. What the patient tells you, and it's fascinating that in migraine, they're very consistent about what they tell you. Each patient doesn't know what the other one says, but they'll tell you very consistent things. If I don't have an open mind about looking elsewhere for the possible cause, then maybe I'll never really find the way to prevent that. So I'd like to give a different way to look at it. It's not my only, I'm not the only person who thinks this way, it's just what the minority opinion is. We'll go to it in a minute. The sleep studies that we saw in my patients were usually not apnea. They were usually a decrease in the amount of REM. It took longer to get into REM sleep. So they basically had REM, but less than they needed. One of my patients actually had 10 hours, completely slept through, 10 hours on her sleep study, no deep sleep at all, none. 18, perfectly healthy, beautiful girl. That's a really bad thing. That means she's aging faster than the people around her. Bad things are going to happen to her in the future. Now, the verapamil I'd given her took away her headaches, but she was still really, really tired. But what happened was I didn't know what to do about that. There were no medicines that give back REM. She's already sleeping. All I had at the time was a CPAP mask and sleeping pills. And I did that for 5 years. But she was sleeping, and she didn't have apnea, and her headaches were gone, but she was really tired, and I saw that she had no deep sleep. Completely confused me. She turned out to have really terrible B12 deficiency with a B12 of about 150. And that was the first time that I thought, oh man, maybe we can replace this chemical, and her little sleep switches know what to do, but they don't have the raw material. You know, it just introduced that idea into my mind. So over a period of time, I did a bunch of things that you guys have already heard about in vitamin D, but in general, what I've found is if you can fix the sleep, you can fix the headaches. Now, it's not always easy, but we're going to talk about why that's interesting in terms of why headaches occur. It turns out not only can you fix them, but they may actually occur having something to do with the sleep switches. So as I learned more about sleep, it affected my way of thinking about migraine. And I kind of think probably most mammals can have migraine. They don't tell us because we can't ask them, but there's no reason why other animals can't have migraine. So here's what I'm going to try to convince you of. Migraine does not occur in the cerebral blood vessels. Sleep and migraine are very much intertwined, both in the anatomy and in the physiology. Migraine is a genetic disorder, and I think that genetic disorder leads to a hyperexcitability of the posterior brainstem, and we're going to go over that in detail. The posterior brainstem nuclei are where sleep happens. So the little switch, it's not that all of sleep happens there, but the little switch that says, okay, you're going to be unconscious and you're going to get paralyzed and it's going to be at 10 o'clock, and then they wake you up at 6, that all happens in the posterior brainstem. And they are designed to turn on and off spontaneously. If you want to or not, you will go to sleep tonight. And then if you're lucky, you wake up again in the morning. Most of the time, you don't have any voice in that. So it's possible that that spontaneous on-off switching mechanism that's designed to make the sleep happen without our consent can actually sort of leak over into other surrounding nuclei. So I want to present you with the old theory that is called the trigemino-vascular theory. This has been in popular use for about 70 years now. It was originally proposed because there is a unique setting in the brain, which is there are no pain fibers in the brain. So if you can stimulate the brain itself when the patient awake and it doesn't hurt, gee, if it doesn't hurt, then it must not be able to make a headache. So the only thing they had to go on was the cerebral blood vessels and the meninges were the only place that hurt when you touch them. So then they generated a theory that had to do with inflammatory chemicals touching the blood vessels, that is where the headache was actually experienced by the patient. Now, is there another opinion? Yes, there is. Put forward actually in the early 80s by a fellow named Michael Welch, who I think is brilliant, and his student Peter Goadsby, and they have written most of the minority opinion. The pain, from their point of view, based on scientific studies, not just made up out of the air, is experienced in the posterior brainstem, not in the nerve ending. So this is some of Dr. Welch's work, just lists of many articles that have to do with imaging, that have to do with experimental paradigms. He had very, very good basis for saying that this is a observation in migraineurs, that it has a very important interaction with the other symptoms of migraine. These are Dr. Goadsby's article. He's really the only person that's carrying on this torch in the article, in the journals. And I particularly have to point out this one to you that he wrote in 2009, The Vascular Theory of Migraine, a great story wrecked by the facts. Here's an explanation of the minority opinion, which I think makes much more sense, and it allows us to then cure headache in a way that we couldn't have if we were focusing on the blood vessels. Their theory is that the posterior brainstem, where the nucleus that receives the input. So this drawing gives you, these are the nerves that feel pain for the face, and they come into this nucleus, the trigeminal nucleus caudalis. Now, it turns out that the back 1/3 of the head and the neck actually feeds back into this nucleus, which is actually in the spinal cord. Now, that's an interesting thing. So it turns out the whole head is not done by this nucleus. It's actually partly by the trigeminal nucleus caudalis, partly by the upper cervical roots. Unfortunately, Dr. Welch just doesn't even go to the headache meetings anymore because he got so abused. I talk to him about once a year, and he doesn't show up anymore because they were so rude to him that he stopped going, which I think is too bad. And if the blood vessels in the past were the only part of the brain, the blood vessels still are the only part of the brain that have a pain supply, it makes sense that we should say they're responsible for the headache. So I want to dispel that problem before we go on to the next. Why wouldn't the brain have pain fibers? Here's what I think. The brain and the spinal cord are very unique. They both have a skeleton on the outside. So my muscles, my liver, my skin, they need a message saying somebody just stabbed me. Well, theoretically, the skull has got this nice bony covering. It prevents you from having a stab wound into the head. So perhaps that means we use that as an excuse to not have pain fibers. Now, the one problem is it doesn't protect you from one thing. When you bang the head, the brain still bumps around inside the skull because the brain is floating in fluid. That means, the surface of the brain still hits on the inside of the skull. So the meninges are one of the ways that we know not to bang our heads. Also, when you shake the brain, those blood vessels are stretched, they're tethered into the neck. So my feeling is the blood vessels and the meninges have pain fibers to tell us not to bang our head. And obviously I'm making this up in a totally teleological way, but that means, that's not the only place that we could think about where we could have head pain. So let's think of it in another way. It doesn't really tell me why it's normal to have a headache, but it does still bring us back to what would be unique about this part of the brain that would mean that humans think it's normal for it to just turn on without a blow to the head. The thing that's distinctive about headache is you're not talking about, I just got hit in the head with a baseball bat, my head hurts. That's post-traumatic pain. Headache is, I'm sitting here minding my own business, my head starts to hurt. So the trigeminal nucleus caudalis, which we pictured in blue, does the front 2/3. The back is done by the dorsal horn for C1 through C4. Now, what's weird about that? Why do these two guys turn on spontaneously? There's actually another set of nuclei that go all the way down the spinal cord. This red one. It's exactly the same anatomically, yet it just doesn't turn on spontaneously. So I was thinking about that a lot because that's what I do all day long, and I had wondered for a while whether or not there might be something close to those two nuclei, the trigeminal nucleus and the upper nerve dorsal horn nuclei, something that only affected those two without extending down into the spinal cord. And it was when I got into sleep that I started to look at the anatomy of the posterior brainstem and realized, oh, what about the sleep nuclei? What about the periaqueductal gray nuclei? This is a picture of the aqueduct that lets the CSF drain out from the lateral ventricles. This area is called the periaqueductal gray because it's next to the aqueduct. And that is where a lot of the sleep nuclei are. That's where the clock, the pacemaker cells are what allows our brain to know that it's 10 o'clock. Every single one of us in this room, if we have healthy sleep, we all get drowsy at 9:30, we all go to sleep at 10, and we all wake up at 6. Now, that's uncommon these days, but that is the way the brain is designed. The way we do that is with these pacemaker cells that are right here. They're the clock of the brain. It doesn't do the complicated things. It doesn't do the work with the hypothalamus or dream. It's just the clock, but with it comes the need for paralysis, which is right here in the same area. So we have a whole set of specially designed cells to put us to sleep and wake us up, and they do that without our consent. They're designed to go on and off by themselves, and they're snuggled right up next to this trigeminal nucleus. Now, why would one area of the brainstem be able to just sort of wash over into another area? That really looks pretty sloppy and dangerous, okay? I'm going to try to convince you that those genes actually are set up into another cell type that could actually make one part of the brainstem affect another, one affecting another. I pulled this picture because it was cute, and it was in Paris, and you hit one, you're going to hit all of them. So there are about 40 genes now, even more all the time. Every year there are more genes for migraine. All of them turn out to be ion channel mutations, sometimes pumps. They're mutations in the way that we change our cells from off to on. Here is a calcium channel. It's a little hot dog bun shaped thing. It sits in our cellular membrane. It's a potential hole. There are many different sodium, calcium, potassium channels in the body. They all have their specific responsibilities. The way the cells turn on, we use these ions that are floating in water instead of ions going down an electric wire, kind of like a battery. These open, calcium goes in, and then the cell turns on. So once the positive charges go in, you have lots of positive charges in the cell, it's on. All of these mutations lead to a malfunctioning channel or a malfunctioning calcium pump, which means that once the channel goes open, it stays open. Oops. You pump out the calcium, but oh, it's still leaking in. So that cell, once it goes on, it can't go off again. So that is a very interesting thing. It could lead to hyperexcitability. It could lead to the cells being in the more on position most of the time. Now, we now have multiple pump and channel mutations, but we really don't know which cell in the brain has these pumps. So these were all discovered by looking at the DNA, looking at a specific gene, showing that it was predominant in a family with migraine, and then saying, oh, it's this channel. But the question is, are these in the neurons? Are they in a different cell? How do these actually result in you having a headache? One, I want to show you a few more pictures, and then we're going to come to what I think is the reason for this. But the pictures are very compelling, all right? Why do Dr. Goatsby and Dr. Welch think that the posterior brainstem is too on? You don't just have to believe me. Is there scientific evidence? Well, this was one of the first studies that showed that if you put a migraineur, and this was by accident, somebody was studying in PET scans for a different reason what the brainstem looked like, and then somebody started to have a migraine when he was in there, and they began to show that the posterior brainstem was lit up inappropriately or abnormally while the migraine was happening. Then there were a whole bunch of other studies that were done in migraineurs that showed when you give a triptan, the excitability of the brain goes down, but the excitability of the brainstem still stays a little up. And there are several references done in several different ways. Magnetoencephalography, this with PET scans. So the next question is, how do these channel disorders make this excitability? Okay? Now, are there other imaging procedures? Yes, there are. And they're important because they were the very first imaging procedures we had, and we really had no explanation about how they worked, but here they are. In the 1960s, they began to enroll migraine patients to watch what was happening electrically. So one of the frustrating parts about having a migraine is you go in and your head hurts like it's exploding, and I do a CT or an MRI and they're normal. It's kind of like saying, my computer doesn't work, I'm going to take a picture of it, I send it to my computer guy online and say, what do you think is wrong? And he goes, oh, it looks fine to me. So the picture is the anatomy. It's the outside anatomy. It doesn't have to do with what the physiology is. The migraine has to do with the physiology. Now, some of the early experiments wanted to see what happens electrically in the brain during the headache, and they enrolled patients who had a visual aura, because otherwise, how would you know when the headache was going to come? So all of the pictures that they did were people who had a visual aura, and what they saw was that there was an electrical change that started at the back of the brain at the time they were seeing the funny images, and then it moved very slowly forward, and it took 15 minutes to go from the back to the front. Now that's a very long time, okay? All of you in the room that knows about neurons, I'm talking a lot faster than that. What would it be that would transmit something so slowly in a wave like that in the brain? I could go down to the mall and come back by 15 minutes. So that was very confusing. What did it mean? Why is it so slow? Why is it moving kind of like when you drop a pebble in water and it spreads like a wave? It's moving in a contiguous way, like sound waves. The neurons don't act like that. So what would be the cell type that would produce that? And what does that have to do with my headache? How does that produce my headache? There was one other thing that was seen at the same time, and that was Dr. Leao, who came from Brazil, went to the Mass General, and did slices of rabbit brain, stimulated them electrically, and then measured this electrical wave, just as like the same concept. Moved at a slow rate, moved at the same rate as those seen on the electrical studies. He showed that there was an electrical change that you could measure with electrodes. It moved at the same speed, and in fact, the drawings and the recording of the visual aura on someone, for instance, a physician, which is what's happened here. This is a physician recording what happens to his visual aura as it gets bigger. The speed at which it moved, the speed at which it spread in these original electrical studies, and the speed at which it moved on the animal brain all was about the same, and it was all very slow. How is it related to the headache, and what is the cell doing this? And this is my dog Bella, who I think does get headaches too while she's in the car. This is where we get into the really good stuff. This is the astrocytes. So there are really a limited number of cells in the brain. There are the neurons that everybody usually knows about, the astrocytes, which we're going to talk about, the oligodendrocyte, which is the cell that makes the myelin, or the insulator, and then the microglia cells, which are the immune system of the brain. The astrocytes have been relatively less famous. When I was in medical school, we thought they were the structural system of the brain because they're shaped like a star. That is why they're called astrocytes. They have these little processes that go all over. We thought they were the structural system. They just kind of made the gooey stuff hang together better. And it turns out once we were able to see them in 3 dimensions with confocal microscopes, we didn't have to slice the brain so thinly to have light go through it anymore. Now you can stain the brain in specific ways, and it turns out that they're actually a lot more important than we realize. In the last 20 years, there's an amazing amount of astrocyte physiology that's very important in migraine. This is a beautiful cartoon of here is an astrocyte. Its processes actually go out and sit on neurons, and it sits on the axons, it sits on the neuronal body, and it has processes that actually make the blood-brain barrier. They surround a blood vessel. This group, the astrocyte, the neurons that they innervate, and the blood vessel are called an astrocyte neurovascular unit. Now this is a very interesting anatomy because what happens here is this little guy can listen to a blood-borne message. For instance, think about what it would be like to wake up your whole brain. You want to wake it all up in the same moment. You don't want to wake half of it up. How could you wake every cell in the brain up in just a millisecond? If you did it by wires hitting every single cell, your head would have to be the size of Tyler. Probably instead what we do is we send out a message that comes chemically with a single heartbeat. It's taken up by the astrocyte. The astrocyte tells all of its 50 neurons, wake up. It allows you to magnify general messages. So the neurons are specifically designed to do certain things. The astrocytes, on the other hand, allow us to raise and lower the excitability of neurons. Now, the other interesting part is astrocytes may have their own special anatomy in terms of regional anatomy, but they have one other really important thing. This depicts them as being chock-a-block next to each other instead of a single cell, because the entire background layer of the brain in which the neurons are suspended is made up of astrocytes. They have this special property where they can open gap junctions between brother and sister astrocytes that allows their ionic environment to be directly shared. Now that's an interesting thing. It might mean that what we saw in spreading depression was a spreading intracellular calcium wave. There's a lot of discussion about what this means, but it does probably mean that this is the population in which the spreading depression occurs. Now, that also might mean that they actually are responsible for spreading depression, and they might be responsible for a few things in the brainstem. So they can amplify a signal. Spreading depression probably is being actually performed by this cell, and it explains one other really important thing. At the time that the spreading depression studies were done, there were parallel studies done looking at the blood flow, and the blood flow did a very similar thing. It decreased in the back and then it moved forward. Well, it was moving in parallel because this astrocyte can affect the opening of the capillary or the blood flow as well. So this attaches both the neuron to the blood vessel and probably plays a huge role in spreading depression. We're going to come back to that in a bit. So I personally think, and as do some other authors, that the changes in mentation that occur during migraine are from the neurons being put to a lower excitability, not from the blood vessels being changed. So let's just summarize for a minute, and then we'll put it all together. Headaches happen equally in the head and neck. I think that's an interesting thing, because the neck is really not in the head. Small headaches can grow into big migraine. Brainstem hyperexcitability has been observed in various studies, different kinds. Astrocyte physiology may explain spreading depression. And I think the astrocytes are probably the cell that's carrying the channel mutation. Now, what is that going to mean to us? First, I want to ask, okay, what about all the other symptoms that my patients tell me about that are almost always there? As the headache gets worse, there are more and more symptoms that come with it. None of these are explained by the vascular theory. Dizziness, very common. Hypersensitivity to light, sound, and smell. Ringing or tinnitus in the ears. A visual aura that we know comes from the occipital lobe. Nausea. We think that nausea is so common with headache that they come together. They're not related. They're next to each other, but they don't always come. If you have a baby migraine, you don't get nausea. When it spreads out into the nausea center, then you get some nausea. Nasal congestion, very common. All the patients who tell me, no, I don't have any headaches. I just have those sinus headaches. Sleepiness, very common in migraineurs during the actual migraine, and then you actually can proceed to a very severe headache that has weakness, aphasia, a very serious alteration in the function of the brain or the brain stem that looks like a stroke. So let's look at the anatomy of that. This is a picture that shows, this is the superior salivatory nucleus. It's right next to the trigeminal nucleus caudalis. This is the one that's responsible for swelling the inside lining of the sinus cavities. This is the chemotrigger zone. It's there to make you eat a bad piece of meat that has icky chemicals in it. It goes up into your brain, it makes you barf, and it saves your life. Okay? It's not there to torture you. It's there for a reason. It turns out that there are several nearby brainstem nuclei that all run in this area that may actually become electrically inappropriately excited by something that's happening near them. So all of these could be explained by things that happen in the brainstem in everyone. There are the cerebellar nuclei right next to it that could cause vertigo or mild dizziness. Hypersensitivity to light, sound, and smell. We're going to show you the geniculates a little bit. We don't really know exactly which nuclei these happen, but tinnitus could happen in the 8th nerve nucleus, which is right next door. Nausea, I just showed you. Nasal congestion, the same. The stroke-like episodes, it's not completely clear whether or not that's happening in the brainstem and the cortex, but this all, I think, is very persuasive that this is an electrical excitability event all happening in the brainstem. Now, let's talk about how the astrocytes are organized in a bigger way. Astrocytes are organized into regions of the brain. They do regional changes that allow us to do different excitability in certain parts. So, what about the visual aura? And any theory that explains migraine has to explain why some migraineurs are only triggered by visual things. Some migraineurs only have a headache that starts with a visual aura, which clearly is not occurring in the brainstem. Here, it's occurring in the occipital lobe. So the next question would be, is there anything about astrocyte physiology that anyone has published that would link the posterior brainstem to the occipital lobe? Yes. They're called PGO waves. They're called PGO waves because pons, which is where it is now, geniculate, occipital. Now, these have been well described since the 70s, 60s during rapid eye movement sleep. They're waves that go back and forth, and they move back and forth at the rate of the eye movements in sleep. But the fascinating thing is you can still record these while you're awake. They're still happening. They're not moving the brain. They're not moving the eyes, but they can still be recorded. Now, could that mean then that there was a special subanatomy regionally that might then be affected by certain calcium channel mutations that would mean the posterior brainstem and the occipital lobe are linked for a reason that has to do with something completely different from migraine. It has to do with sleep. It has to do with rapid eye movement sleep. Things we don't understand yet, but still that existing subanatomy is there even though we don't understand it. So the next part is, why are all these waves and all this astrocyte anatomy important? Because we want to get rid of the headaches. And if we understand the actual physiology, we can get rid of them a little bit better. So I think that the same astrocyte population that affects the excitability of these sleep switches probably is active throughout the whole posterior brainstem. That there are astrocytes that cross over the anatomy of one nucleus to another nucleus in a way that neurologists were really not trained. We show these little pictures of clumps of neurons without knowing that there is another population that crosses over that. Since sleep is one of the most important things that we do every day, it makes sense to me that if you get a gene that makes your sleep switch turn on more easily and perform more normally, then you really do have a survival advantage. So my hypothesis is these genes that we can find throughout the whole population are actually being transmitted for improvement of sleep. And the headache is an unexpected or an unwanted byproduct. Okay? Now, key points of this, and then we'll go on to how to get rid of them. I think that the literature that suggests that the posterior brainstem is too hyperexcitable is well documented, and that most of these other symptoms can be put into that same area. Now, it doesn't prove that this is right, but we're still back here. I'm lying by the pool, I don't have a headache. The rest of you who do have migraine are still looking at those clouds going, great, she explained how it happens. I still have a headache. That storm's coming in. Let's get rid of my headache. So here's the next part. How do we fix it? How does understanding this brainstem stuff help us go in a different direction? Because the odd part is the science of neurology has moved dramatically in the last 50 years. Migraine is stuck back in the 1960s. When we go to the meetings, the migraine literature is really lacking. You know, nobody's come up with a new idea, and especially they haven't come up with a way to prevent the headache. Great, I give you a medicine, it gets better. What about all those daily headache sufferers? They'd really like to have it gone. Let's find a way to prevent them. First question is, if I've had this mutation and it's a genetic disorder, how come it didn't affect me until recently? What made it turn on now? Because if it wasn't on before and it's on now, and I can figure a way to switch it off again, aha! Now you had the gene, you've always had the gene, but you don't have the headaches. That's a powerful thing. So what I learned, and completely by accident, was if you can fix the sleep, you can fix the headaches. And it was absolutely observational. I would have never gone there. My patient made me do a sleep study. But it's interesting that once we get these mutations, the medications that we've used all along are calcium channel blockers, verapamil. We neurologists aren't that smart. We fall into these medicines. In fact, we're desperate. We'll use anything. Any new seizure medicine comes along, we'll use it for your headaches. The second group is sodium channel stabilizers. Well, these both fit beautifully with the mutations. How come the headache people are still talking about the blood vessels? So they work by stabilizing hyperexcitable channels. So let's figure out, how do we get those guys to go off and stay off? It's interesting that most of us in the room have an occasional mild headache. We think it's normal, okay? But what that means to me is you have the migraine gene. You're able to make a migraine. You're just making baby migraines, okay? That means you have the mechanism, but because of some other thing, you haven't moved on to what my patients have, which is a daily terrible headache that makes their life miserable. You want to go back, if you have daily headache, to this mild occasional headache. You want to make those cells become quiet enough that you only have a headache occasionally. Even when the storms come in, you don't get a headache. So how do we get back to being one of those people? Here's what I learned from the CPAP masks. Why did the CPAP mask make my patients' headaches better? What we had in the literature was fat older males, poor oxygenation to the brain. I don't think so. The masks are not about getting oxygen to the brain. First, my patients did not have drops in their oxygen. Two, the thing that brings oxygen to the brain is the blood vessels. Okay, they bring oxygen to the brain. That doesn't have anything to do with what we saw. But what I did see was these young, healthy people, they would sometimes have apnea, and interestingly, we get the most paralyzed of all in REM sleep. We have to have this period where we're dreaming, we're very active, our brain is going wild in there, and you don't want to talk, you don't want to move, you're going to fall out of your little nest in the tree, or you're going to cry out and the lions are going to eat us. This is very important that we have to be paralyzed. Also, it turns out probably we have to be paralyzed to repair all of our moving parts. Anything that's moving has to be paralyzed in order to fix it. So it turns out that the paralysis system is getting goofed up in my patients. Now, it doesn't really say why they don't have REM, because it may be that they just don't get into REM. Doesn't have anything to do with paralysis. They may just not have a switch that's flipping. The mask only allows the brain to stay into deeper sleep by blowing air in. That doesn't provide any raw material to the brain that's different. It just allows it to stay in deeper phases of sleep for longer. Now, these are those pacemakers. This is the area that determines when we sleep. These two are very heavily intertwined. I spent a lot of time thinking about these cells. This is what they would say when they come back. Well, my headaches are gone, and you know, I'm only on 2 blood pressure medicines now. And oh, by the way, they took away my metformin. I'm not on any pills for diabetes. And I went, wow, that's an amazing thing. And there's lots of articles showing that if you put a CPAP mask on somebody's face, their blood pressure gets better, their diabetes gets better. Then they would come in and say, my knee pain is gone. And then I'm really blown away. Your knee pain's gone? What's up with that? And all I can think of is, oh, maybe their legs stopped moving. I don't know. And oh, my memory's better and my thinking is clearer. And I began to get this feeling that everything in the whole brain, including below the neck, areas that I don't necessarily think about, the pancreas, they're all repairing while we're in sleep. What would allow us to repair all of this stuff? And then it seems just logical to me that the only repair we ever do is while we're sleeping. And I say that based on these patients that I see who I know have not gotten into deep sleep for the last 20 years. And they're not living a good life. They're in the hospital. They are a wreck. They have multiple medical problems. And they all don't sleep. That means this part of what we're doing, this 8 hours, this is the most important part we do every single day. And it's not good enough to just lie down. Lying down and becoming unconscious is not the story. You have to get into these work phases of sleep to repair your body. Because I would see the patients come back and say, well, my headaches aren't gone, but it's interesting, I'm not waking up with a headache now. Last month, I would wake up and it would be no headache, and then the headaches would come at 10 in the morning. Well, this month, they're coming at about 5 p.m. My tremor patients would say the same. First month on the CPAP mask, oh, well, actually I don't have a tremor when I wake up, but later in the afternoon, it comes back. So there was this consistent reporting which suggested that they would make their own chemical that would turn off the tremor, and then if they didn't have enough, it didn't last all day. They ran out at 3 p.m. And then if we can get the sleep good enough for long enough, they'll make enough to last through the whole day, and then they don't have a tremor or a headache the whole day. And it was so consistent within the various patients that I would send that I began to think that, you know, we really only repair and sleep. It's odd that we still have publications that say, oh, we're just laying down, we want to conserve energy. You know? Well, I could do that. I could conserve energy, but you know, if I just lay down and I don't go to sleep, wow, we don't feel good. So going back to that 18-year-old patient who had no deep sleep, I think that is a very important patient because she slept all night. That makes it very important. There are plenty of people who know they don't sleep well. But there are also lots of people who sleep but feel crummy. That means, you really need to be asking the next question. How do you feel when you wake up in the morning? And it turns out that if you wake up in the morning, you have a headache, or you feel tired and you don't feel good, your sleep is not normal. You may not know it's not normal, but if you do a sleep study, you will find that they do not have the proper phases of sleep carried on for as long as they want, long as they feel that they need to feel better. I think that most of the chemicals that we make to prevent the headaches from coming on are made while we're in these deep sleep. So there's another concept that why isn't there any REM, and then how can we make it back? So one of the things that happened to me before I got into how to fix the headaches was, gee, this is really weird. I started sending all my other patients for sleep studies. It's not just headache. Every patient who comes to see me, little kids with a tic disorder, little kids with seizure, little kids with headaches, they don't have any REM sleep. This is an epidemic. This is an epidemic throughout all ages, and I happen to know that it started in the early 80s because I'm old and I lived before and after that. I know that the guys who went to high school with me did not stay up until midnight. So we say that it's because they're on the internet too much. Well, it's because they're not asleep. So I have now developed my idea of how I think of it, which is, I think we make chemicals while we're sleeping. We make chemicals that do everything our body needs. You store them in your little cell. So the pancreas is making little packets of insulin. They pack the whole cell, all the islet cells packed with insulin. If you run out before the end of the day, you don't have enough insulin and you have diabetes. If you don't pack your little cells with enough neurotransmitters, you have packets of serotonin, you run out, you're depressed. That's very, very oversimplified, but the general idea is, gee, if you don't make enough of your chemical, you come to me and I give you mine. So I give you a serotonin reuptake inhibitor, I give you metformin, I give you whatever it is, the patch that goes over the chemical that you didn't make. Now, what that also implies is, what if I could get you sleeping better and you make your own chemical? Now, that became very attractive to me because there are at least 40 different calcium channel mutations, or 40 different channel mutations, and I've already practiced 20 years with the preventatives. They're only partially successful. That's really depressing for me and the patient. Even when they're a great success, they tend to wear off. Now, what if I could get your brain to make the chemical you were making before the headaches came? Now, I don't even know what that is, but if I can get you into sleep, theoretically, you get back to making whatever it was you were making before the headache started. So it's a very attractive idea, and in fact, it turns out with the CPAP mask, which is not a drug, you can actually get people into deep enough sleep that they're doing something that takes the headache away. So the next part is, I want to find something that's going to bring back the REM, but I don't have any medicines that do that. Xyrem is the only one. It's the date rape drug. Like, I'm really going to give that to my 30-year-old patient with 3 kids, you know? It gets you into REM and then you can't get out. Bad idea. What I want is, how do I get your sleep to be really normal again? All right, I'm going to talk a little bit about vitamins, but as a preview to that, and all those of you that want to see this part of how to fix your headache, you have to go to the vitamin D lectures to do that. Be careful with these chemicals. We've been brainwashed into thinking vitamins are no big deal. They are dangerous. They're chemicals. They will mess you up if you don't know what you're doing with them. So by accident, I actually fell into this vitamin D stuff, and then I really got interested in what would be the chemicals that would make my patients sleep normally, and it turns out to be a cascade of problems. So it's not just the vitamin D. Vitamin D by itself wears off in 2 years, and you will get other problems if you just use the vitamin D and you don't fix the intestinal bacteria. So it turns out that there's a cascade of events that happens with a low D. A low D environment in your intestinal bacteria actually gives a favoritism to certain bacterial types that make you fat and also give you IBS, but it also means that they are not the ones that make your B vitamins. So it's a little complicated, and I'll refer you to the other lectures if you want to know the details. The last one, called Sleep 202, has a whole discussion of this, but most of the humans that lived before doctors arrived actually didn't take vitamins. That's surprising. They didn't even listen to those junior high school lectures about a well-rounded diet. We didn't have them. The squirrels in my backyard still don't listen to those lectures, okay? Yet, we know that people could live to be 100. So that's a basic concept that's in the background, in my mind. Most of the people in past years died of infectious disease. I'm not seeing much infectious disease. My practice is not filled with polio, syphilis, diphtheria, tuberculosis, leprosy. I'm not seeing those patients. What am I left with? Most of the things I see are actually genetic diseases: vertigo, migraine, Parkinson's, Alzheimer's disease. Now, these are the other things that you guys see in general practice: stroke, heart attack, diabetes, Parkinson's, Alzheimer's, cancer. All of these, in my view, result from incomplete healing. And let me just state that I have not ever seen an Alzheimer's patient recover their memory from getting their sleep better. They're a lot more pleasant to deal with, but they do not get their memory back. So from my point of view, this is the one disease that if you don't get it way before it starts, making them sleep better doesn't help, but headache responds beautifully. Now, there's an epidemic of low vitamin D. Go to the vitamin D lecture. When we get the REM to come back, the headaches go away. There's some specific ways that that's going to happen, but I want to explain just in a general sense that you can't just use the vitamins in most of the patients. In a 16-year-old who walks in to see me who's had headache for the first time in their life from March to June, it's easy. You give them vitamins, you tell them to go outside in the summer, you tell them to get an outside job and use sunscreen, but only do it at the beginning of the summer. They never come back, and they're very happy. It is not that simple in somebody who's had daily headache for 30 years. There's a basic concept here, and the reason why it's successful in my hands, and it's not that successful if you just want to sprinkle vitamins on people, is I did 5 years of these sleeping pills. You have to know a lot about sleep. And what happens is these people who have had daily headache for 30 years, and all of our hospitalized patients who are really sick, they have not been fixing their own sleep switch. So the only time that the sleep switch has chance to repair itself, to do cellular metabolism that repairs all of the processes that make it work well, is while it's sleeping also. That means I'm working with somebody who's got a rusty, gimpy sleep switch, and if all I'm going to do is give them vitamins, most of the time we don't succeed. If they sleep and then there's no reason to give them sleeping pills, then we don't. But if they don't sleep, the only time the repair happens is while they're sleeping. That means we usually have to use sleeping pills. Now, the sleeping pills have gotten a very bad reputation for a good reason, but if you give the sleeping pill and you don't fix what's wrong in the background, then you just need more sleeping pills, and like all the headache preventatives and everything else, slowly over time the disease gets worse and you need more sleeping pills. So we say that you're addicted, and then you take more of them, and then you're staggering around like a drunk and you get admitted to the hospital and we take the medicines away. So we're using them, but we're not using them in the right way. They're only a patch. What you want is to use these medicines while the patient is trying to get into sleep and is unsuccessful. Now, here's the way you know that it's the right medicine. And what you're really doing is the same concept. I'm trying to duplicate a chemical that the brain doesn't have enough of, okay? How do I know? This is how you know. You fall asleep, you stay asleep, and you wake feeling great. So I tell my patients, when I give you one of these sleeping pills, I wish I had a little transponder that I could attach to your neck and see which chemicals are not going up and down in the right way. And I can say, oh, it's this one, we'll give you that. I don't. We're not even close to that. It's even a fantasy of my mind. That means I have to give a sleeping pill, and then I say, this is what you want. You don't want to be dopey. You don't want to fall in the middle of the night. You have to be able to get up, take care of the kid that's crying, come back to bed, be completely cognizant if there's a fire, and you get back in bed, you fall asleep, and you feel great in the morning. That's when you know you got the chemical the brain really wanted. Many times you will have to try several sleeping pills before that happens, and there are a lot of them. It's very helpful to have someone who knows about the different categories so that you can kind of know, oh, I tried this one, I had a bad effect, oh, this one is kind of similar to that. And we're finding new things all the time, and they're making new medicines, but one, you have to listen to the patient. The side effects from the medicine, very important. That means you come back, you say, oh, I hated that one, and you go on to something else. Until you actually accomplish sleeping through the night, the headaches won't go away. Anybody who has to use CPAP, anybody who's documented to have apnea, they have to be wearing this mask. Now here's the problem. Most of my patients couldn't sleep. So you strap a mask on their face, that doesn't make them sleepy. That makes them frustrated and angry. So they better be sleeping when the CPAP is blowing air. It doesn't help them at all if they're not asleep. So in the apneic patient, you still have an obligation to get them into sleep so the mask can help them. One of the really interesting things I'm doing more and more is if the patient tells you that they sleep better in the afternoon in the recliner, encourage them to stay in the recliner. They just learned that their body feels better because they're upright, the airway is in a better position. So in my patients who have bad sleep apnea, I encourage them to put the CPAP next to the recliner. One of my patients last week says, you know what's funny, you just told me to sleep in my recliner. I sleep from about 8:30 at night until about 10, and then I'm wide awake and I try to go to bed and I can't fall asleep. And you know what? My mom slept on the couch for the last 10 years of her life. That's so weird. Well, her mom had a little Parkinson's disease, and this lady does too, and it affects her ability to get her airway paralyzed correctly. So if you do better, listen to your body. It will tell you when things are going a little bit better. One of the things that always stands in the way of any of these interactions with patients is if I'm convinced that I know better than the patient, I don't listen to what they say. Most of the stuff that I put in this lecture all came from the patient telling me what they experienced. The drugs that I have will also hurt you later. Okay, so we've seen many of the patients go through, I love Topamax, it took my headache away, uh-oh, it's not working now, uh-oh, it wore off. When you get better, it actually goes through the same thing. I learned that with my CPAP patients. They'd come in and say, I don't love this CPAP, but I'll tell you what, I don't have any headaches now, and I'm afraid to tell you this, but my hands and feet are tingling, and I feel kind of stupid in the morning, and I'm wondering about that Topamax. Now, don't take it away, because that's what saved my life. And I say, how are the headaches doing? I haven't had any headaches in 3 months. Okay, well, funny, that tingling and I'm stupid is what the patients say when they don't like Topamax, which kind of suggests you don't need it anymore, so let's try to taper it down. What I notice in my patients is they get better, and then the next phase is you better be able to recognize that the sleeping pill they've been on for the last 3 years, they call you up and say, I just fell out of bed, what's happening to me? They think it's a new event. It's the trazodone they've been at 150 milligrams for the last 3 years that they don't need anymore. So you get accustomed, oh, I need to take these pills. You're not thinking about it, but as the patient gets better, keep an open mind about, oh, as long as the symptoms are gone, these medications may cause new symptoms. We always tell people who do CPAP, oh, if your blood pressure goes down, you may not need the 4 medicines anymore. We have to watch what your blood pressure is doing. Same thing with the sleeping meds, same with a lot of the other medicines that we use. So when the sleep gets better, pay attention to what happens to your body. And then the next hard part is anybody who tries to use this hormonal manipulation, which is what vitamin D is, it is really hard to keep it in range. So once we get the headaches to go away, what we're counting on is you keep the vitamin D between 60 and 80 for long periods of time, years. That gets you good sleep. Now, the problem is everybody needs a different dose. And it turns out in the third year, the same person needs a different dose than they did in the first year. Very confusing. That means every single person, as they get better, I have to go through with them, okay, let's establish in you personally, what are the symptoms that will tell us that you just had a night with not enough REM? How can I look inside your sleep? Because this may happen 2 years from now. And it turns out if the headache was the last thing to come, I have to remember to keep reminding them, remember when we first saw each other that you told me you had depression when you were a teenager, and then you had a tremor in your 30s, and now you have headache, because the headache is the first thing to go away. Now the tremor goes away. But they don't think, because they've had depression their whole life, that depression has anything to do with what we're doing. It does. The mood change for that person was related to their sleep being bad at the very beginning. So once I go through this whole discussion, then there's 2 years of getting the patient to recognize one of the things that will tell me that I've been doing everything Dr. Gominak told me. They always come, I do what you tell me. No, it's not that simple. You can't just keep taking the vitamin D and not pay attention to your body. As soon as you start to feel that change in mood or the tremor gets back, if you pay attention to it and you go, oh, I remember she told me about this, I'll go get my vitamin D level, and you get it adjusted so it stays right where it is, then the headaches will never come back. But you do have to work at it for a while. Some of my patients, they stay at the right level forever and they don't do anything. That's pretty rare, maybe 20%. Most of them really have to kind of work at it. And I was completely caught off guard by the fact that my sickest patients who have needed huge doses at the beginning, up to maybe 30,000, 40,000 a day for a year, finally over 3 or 4 years, kind of taper down, and now they're taking 10,000. It's as though you're using a lot at the beginning. I really did not expect that because that's not what's written. The most important thing for the migraineur is this idea that the little headaches are the same. They're just smaller. Because if the little headache comes back and you haven't had any headache for 4 months, that little headache, if you ignore it, that means, uh-oh, something's wrong in my sleep. If it's only one and then it goes away, never comes back, then you can ignore it. But if you have 3 in a week, you better be going in there and getting your vitamin D level done to make sure that your sleep is going to stay good. If you do that right at the beginning, then you adjust it, then all you ever get is little tiny headaches that you use as a warning. The headache meds are still really important, and really important message. Any daily headache sufferer who has used the triptans, they don't work. This is why we're in here having a discussion. If I had a great medicine for headaches, we would just be giving out that medicine and I would be buying stock in that company. These triptans, they're terrible for daily headache sufferers. You know, they come in and say, I have a headache every day, I'm already on Norco, I want some OxyContin, the narcotics don't work, they make them more depressed, I don't have anything that takes the headache away. They're way past the time when you gave the Demerol, they went to sleep, and the headache went away. The triptans just really don't work very well for those patients. But even if they gave side effects at the beginning, and I'm going to tell you a little bit about that, they will work later. If you can get the patient to have 1 headache a week and no headaches, I mean 0 headache, neck isn't tense, head doesn't feel funny, then they start to have a headache, then these triptans will work for them. The side effects that come with the triptans are related to the fact that you do not have the right amount of serotonin, I think. So the side effects are much more common at the beginning. In the really sick patients, usually you can minimize them. So don't stay away from the medicines. The preventative medicines are still valuable. The triptans are still valuable. But if you can get the sleep to be better, then these medicines will be effective and they'll work and the headaches will go away. Always have a CAT scan. This is very important. There is not a single person in this room that can distinguish what it feels like to have a headache from a brain tumor compared to a headache that's just a headache. CTs are cheap. Get one, make sure your brain anatomy is okay. And I'm going to close out the lecture, and I'll now take questions.